Closed treatment of sternoclavicular dislocation, without manipulation. With manipulation, the physician treats a dislocation of the joint between the sternum and the clavicle, sternoclavicular. The physician applies a splint or brace to hold the joint in place until it has healed. In 23,525, manipulation is required. Anesthesia may be necessary. The physician pushes, pulls, or moves the arm and chest to restore the joint to correct position and alignment. After manipulation, the patient is placed in a brace or splint. Closed treatment of acromioclavicular dislocation, without manipulation. With manipulation, no manipulation is required and the physician places the affected shoulder and arm in a sling or other brace. In 23,545, manipulation is necessary to correct the dislocation. Anesthesia may be needed. The physician manipulates the joint by pushing or pulling on the shoulder and arm to align the bones. The physician applies a sling or other brace. Closed treatment of shoulder dislocation, with fracture of greater humeral tuberosity, with manipulation. With the patient positioned prone and the arm hanging toward the floor, manual distraction is attempted. If not successful, the physician may hang a 5-pound weight from the arm in an attempt to reduce the shoulder into place. Once shoulder reduction is obtained, a neurovascular examination is performed and treatment of the humeral tuberosity fracture is addressed. The arm is immobilized for 3 to 6 weeks. Closed treatment of shoulder dislocation, with surgical or anatomical neck fracture, with manipulation. With the patient positioned prone and the arm hanging toward the floor, manual distraction is attempted. If not successful, the physician may hang a 5-pound weight from the arm in an attempt to reduce the shoulder into place. Once shoulder reduction is obtained, a neurovascular examination is performed and treatment of the humeral surgical or anatomical neck fracture is addressed. The arm is immobilized for 3 to 6 weeks. Closed treatment of radial head subluxation in child, nursemaid elbow, with manipulation. The physician performs closed treatment of nursemaid elbow in a child with manipulation. To realign a subluxated, partially dislocated, radial head, the physician supinates the forearm, palm upward, while flexing the elbow. No incisions are made. If stability of the radial head is questionable, a cast or splint is applied with the elbow in 90. Closed treatment of radiocarpal or intercarpal dislocation, one or more bones, with manipulation. The physician repairs the dislocation of radiocarpal or intercarpal bones with manipulation. Sustained traction is held while the physician applies force to reduce the dislocated bone, into the proper anatomical position. Immobilization post-reduction depends on the physician's preference. Closed treatment of distal radioulnar dislocation with manipulation. The physician performs a closed treatment of distal radioulnar dislocation with manipulation. The physician reduces the dislocation by pronation, if the ulna is involved, and supination, if the ulna is dorsal. The arm is immobilized. Closed treatment of lunate dislocation, with manipulation. The physician treats a lunate dislocation with manipulation. During sustained traction, the physician applies force to reduce the dislocated lunate. Immobilization post-reduction depends on the physician's preference.
Closed treatment of carpometacarpal dislocation, thumb, with manipulation. Closed treatment of carpometacarpal fracture dislocation, thumb, Bennett fracture, with manipulation. The physician manipulates a carpometacarpal dislocation or fracture dislocation of the thumb to restore anatomical position. the physician determines the dislocated position of the bone. The bone is relocated to correct anatomical position using external manipulation, and the hand is splinted.
Closed treatment of temporomandibular dislocation, initial or subsequent. The physician repositions a dislocation of the temporomandibular joint. No incisions are made and no intermaxillary fixation is used. The physician corrects the dislocation manually to rearticulate the joint. Closed treatment of temporomandibular dislocation, complicated, e.g., recurrent requiring intermaxillary fixation or splinting, initial or subsequent. The physician repositions a dislocation of the TMJ. The physician corrects the dislocation manually to rearticulate the joint. Intermaxillary fixation is applied. The physician wires arch bars to the upper and lower dental arches with individual wire ligatures around the teeth or uses other wiring and splinting techniques, and the jaws are wired together. Closed treatment of distal femoral epiphyseal separation, without manipulation. With manipulation, with or without skin or skeletal traction. An abduction type separation is caused by a blow to the lateral side of the distal femur. There may typically be a fracture in conjunction with the epiphyseal separation. If alignment and stability are adequate, a single hip spica cast is used with the knee immobilized in extension. Closed reduction is attempted first in a more problematic fracture or separation, such as in a hyperextension injury. If this is unsuccessful, the physician may insert a Steinmann pin in the femur above the fracture or separation, and another pin in the proximal third of the tibia. Gentle skeletal traction is applied to disengage the fragments while the physician reduces the displacement. A hip spica cast is applied with the knee in 45 to 60 degrees of flexion. In 3 to 4 weeks, the cast and pins are removed and an above-knee cast is applied. Closed treatment of craniofacial separation, Leffert 3 type, using interdental wire fixation of denture or splint. The physician treats a craniofacial separation, Leffert 3 type, without surgically opening the fracture but with the use of interdental wiring of denture or splint. The physician uses surgical instruments intranasally and intraorally to reduce the separation. Intermaxillary, interdental, wire fixation is used to realign the fracture. A custom-made acrylic splint or the patient's dentures are wired to the jaw to provide for the necessary fixation. Arch bars are placed onto the patient's upper and lower dental arches with individual wire ligatures around the teeth. The fracture reduction is maintained in proper occlusion by securing the maxillary and mandibular arch bars together for immobilization until healing is complete.